Well, thank you very much. This is Ike Ahmed from the University of Toronto. It's my pleasure to moderate this session on MicroPulse Laser Trabeculoplasty with kind support from Iridex and BMC for running the webinar. It's my pleasure to introduce our two speakers shortly. And my job here is to moderate this session on new technology, MicroPulse Laser Trabeculoplasty. Now, when we talk about glaucoma therapy, I like to think of glaucoma as moving into an interventional type of disease. And this slide kind of describes where we're at with some of these technologies. As we've seen over the last few years, glaucoma therapy has moved more into an interventional type of therapy. I think we're reconsidering the paradigm shifts in terms of managing glaucoma, and with the introduction of, for example, microinvasive glaucoma surgery and other laser technologies, it's given us consideration of what exactly is medically, maximally tolerated medical therapy. And this has led to the term interventional glaucoma, an idea that glaucoma may be best treated by non-medication alternatives, including laser trabeculoplasty, microinvasive glaucoma surgery, and surgery in general. And so laser trabeculoplasty has been, of course, an option for our patients for many years now. I think we're currently and we're continuing to reconsider where its place is, and I hope this discussion will further add options and ideas around this therapy. Now, one thing before we get into our discussion by our two speakers, I think is worth highlighting is what is MicroPulse. And I think as ophthalmologists, as cataract surgeons, it's a term that we're familiar with, of course, with phacoemulsification. And those of you that are familiar with aesthetic lasers, whether it's skin or hair removal, of course, have also heard the term MicroPulse. And the idea here is basically to use the advantages of conventional laser therapy, i.e. continuous wave, and break up the continuous wave into very small, discrete micropulses. And this allows basically energy to be delivered, but a cooling period in between that energy delivery to allow a reduction in thermal buildup. Essentially, this allows the tissue to attain a cooling factor to prevent collateral damage. And as you can see from the pictures on the right, essentially, laser energy can be divided up into different methods, whether it's a high, medium, or low duty cycle. So basically, the idea here essentially is to attain the effect of the laser without some of the damage that occurs from laser therapy. Now, we've seen MicroPulse in action with retinal laser therapy, and this diagram nicely shows some of the difference in action. Now, with conventional laser therapy, we typically get a laser burn. In that area of the burn therapy and the collateral damage, there's really very little benefit in that laser burn, but the benefit is the collateral biological action that occurs, whether it's inflammatory or other mediated actions that surround the laser itself. When we talk about MicroPulse laser therapy, the idea again is essentially the laser application is made in a less traumatic way, and therefore the mediated action, in this case, for example, a biological mediator mechanism, is attained within the actual applied site of action. And so there's much less collateral damage that can occur, and the idea here again being that we retain the action of the laser itself. Now, to help us with this discussion, we have two excellent speakers that I'm very happy to be moderating with. And our first speaker is David Gossage. Now, David Gossage is the medical director at the Gossage Eye Institute in Hillsdale, Michigan. He's a clinical associate professor of ophthalmology at Michigan State University in East Lansing, Michigan, and he has a major interest in teaching. In fact, he teaches across the continental U.S. And takes students from a variety of campuses across the country. He is very active in residency teaching at Michigan State University and is program director there of the residency program. And we have the advantage here of David being a comprehensive ophthalmologist, a lot of experience with different technologies, specifically with MicroPulse laser technology, not only with glaucoma, but also in retina as well. And I've had a chance to hear some of his talks and look at some of his data. And he's been out there now as far as having some early experience with this technology, and I think we'll be able to add a lot of value to understanding where this will fit with our glaucoma patients. So I'm happy to turn over the microphone to David, and thank you, David, for being part of this webinar.
Thanks, Dr. Ahmed, for that great presentation. I do want to thank Iridex for their support for tonight's program. Some of my goals for tonight is I'd like to talk to you a little bit about how we can use the MicroPulse for the anterior segment for treatment of glaucoma, as well as the treatment of the posterior segment for conditions like diabetic macular edema or branch retinal vein occlusions, and how the IQ532 laser with MicroPulse is an excellent choice for that of the comprehensive ophthalmologist and how I use in my practice. When we look at a MicroPulse treated eye of the trabecular meshwork under electron microscopy, using 300 milliseconds and a 300 micron spot size and 1,000 milliwatts of power, we really don't see any change in that in the MicroPulse treated eye versus that of the control. And like Dr. Ahmed talked about regarding the use of the laser and how the MicroPulse is segmented into small little boxes of treatment, we know that we don't develop the thermal effects that we'd see with a continuous wave laser. Therefore, we don't have the thermal destruction of the tissue, but we still have the mediators that are liberated to be able to create the treatment and desired effect that we want. So with laser trabeculoplasty, we use the laser energy to treat the trabecular meshwork, and this will increase the outflow facility. Now, our main indications for laser trabeculoplasty is that of patients with elevated intraocular pressure. Now, it's effective in treating the intraocular pressure, whether it's a patient with primary open-angle glaucoma, pigmentary glaucoma, or pseudoexfoliation glaucoma. Now, with the treatment of the laser, we really don't want to use laser trabeculoplasty, whether it's SLT, ALT, or MicroPulse laser trabeculoplasty, for treatment of patients who have problems like neovascular glaucoma or uveitic glaucoma, or have synochial closure or peripheral anterior synechia within their angle, because this would be very difficult to treat and it would not respond. Now, initially, we didn't really know what type of settings we should use for the treatment of MicroPulse laser therapy, and I started off using 300 milliwatts of power. I currently looked at 13 eyes who were newly diagnosed with open-angle glaucoma. Now, these patients elected to undergo MicroPulse laser therapy, and the mean IOP was 26 millimeters of mercury with a range of 21 to 38 millimeters of mercury. Now, none of these patients had any previous treatment. However, 5 of them did have ALT in the fellow eye. So initially, I used the IQ532 laser by Iridex, and I treated 360 degrees of continuous spots. Preoperatively, just because of previous experience with argon laser trabeculoplasty, I used bromidine 0.15% along with prednisolone acetate of 1%. I also used a rich 4-mirror lens for the treatment. Now, my treatment parameters at first was using the 300 micron spot size and a power setting of 300 milliwatts, the duration of 300 milliseconds, and a duty cycle of 15%, and treated 360 degrees. The slide on the right, the picture on the right, is actually a screenshot which will show you all your parameters. So anytime you're concerned about what the size of the spot size is or the duration or power, it's easily seen on the front console of the Iridex machine. At 4 months, we looked at our results. Initially, we had a preoperative IOP of 25.7 and a postoperative IOP of 21.1, or approximately an 18% reduction. We did have one patient who had 1 millimeter rise in pressure, which was patient number 11, so they had a 5% increase in intraocular pressure following treatment. This patient actually underwent subsequent ALT, and with the ALT procedure ended up with no change either. So whether this patient was going to be a laser non-responder or not, it's hard to say, but they had no response whether they had a traditional ALT with continuous wavelength laser or with MicroPulse. We then looked at a 700 milliwatt trial looking at 14 eyes of patients who elected to undergo MLT. Now, the mean intraocular pressure was 23 millimeters of mercury with a range of 19 to 26 millimeters of mercury. Now, none of these patients have had previous MLT treatment, but 6 eyes did have previous ALT treatment, and 2 eyes were also on medications. We used the 700 milliwatts of power and a spot size of 300 microns and duration of 300 milliseconds. Once again, the duty cycle for using for MLTs is 15%, and the treatment circumference should be carried out for 360 degrees. At 1 month postoperatively with 700 milliwatts of power, we saw the initial preoperative IOP of 23 and a postoperative IOP of 18.9, or a 17.8% reduction in IOP. If you look at patients 3, 4, 7, 8, and 11 and 12, all those patients had had previous ALTs, and patient 3 and 4 were also on pressure-lowering medications. By 4 months, we saw the preoperative IOP of 23 and a postoperative IOP of 18, or approximately a 21.7% reduction in the IOP, so a slightly better improvement at the 4-month period. However, at 4 months, we did have one non-responder, patient number 14, which didn't have any elevation in pressure, but also showed no improvement with laser treatment. When we looked at the no laser versus previous laser group at 1 month at 700 milliwatts, the no previous laser treated eyes started off with a pressure of 24.1 and a postoperative IOP of 19.8, or a 17.8% reduction. If they had previous laser, the initial preoperative IOP was a little bit less of 21.5, which is understandable because they've already had previous laser therapy to bring the pressure down. And postoperatively was 17.8 or approximately 17.2% reduction in IOP, very comparable whether they've had previous treatment or not. Now at 4 months, we did see in the previous or the no previous laser treated eyes a 24.1 preoperative IOP and a postoperative IOP of 19, or approximately a 21.2% reduction. If they had previous laser, it was a 21.5 preoperative IOP and a 16.7 postoperative IOP, or 22.3. So actually those patients who have had previous laser therapy did respond to the laser and actually respond just a little bit better in MLT if they've had previous laser before. So I thought that was kind of interesting to see, and it made me feel very comfortable of using that as an adjunctive tool to treat people who have IOP that you want to bring down just a little bit lower, and you're concerned if they've had previous ALT or not, whether or not they're going to respond to this laser. And I felt very comfortable after looking at these numbers to go forward and treat these patients with MLT. I then looked at using 1,000 milliwatts of power on 18 eyes. Now all these patients elected to undergo the MLT. Their mean IOP was 23.9 with a range of 19 to 39 millimeters of mercury. Now any patient was admitted to this trial because I was feeling really comfortable using the MLT therapy, so I would allow patients who had previous ALT, MLT, or were on current medications to be enrolled into this treatment. We once again used 1,000 milliwatts of power, spot size of 300 microns, duration of 300 milliseconds, and a duty cycle of 15%, once again treating 360 degrees. So at 1 month post-treatment with 1,000 milliwatts of power, we had a mean IOP of 23.9 and a postoperative IOP of 18.7, or a 21.8% reduction in power. There was one non-responder, patient number 11, who showed no change in pressure. By 4 months of post-treatment, we had initial IOP of 24. This was because patient number 9 and 10 were actually removed from the study because they didn't follow up at the 4-month follow-up appointment. But our postoperative IOP was 16.8, and this is where I thought was pretty amazing, is that we saw a 30% reduction in IOP at 4 months with 1,000 milliwatts of power. So I was pretty impressed to see the amount of change that we can see, especially using the higher amounts of power. The other thing I was impressed to see is that we had no non-responders in the 16 patients that did follow up at 4 months after treatment. So the question was that I had is, what power setting should we use? Well, when we looked at 300 milliwatts of power, at 4 months we saw about an 18% reduction in pressure. With 700 milliwatts of power, at 1 month we saw a 17.8% reduction, very comparable to that of the 300 at 4 months. But by 4 months in the 700 milliwatts of power, it was already a 21.7% reduction. So at that point we knew 700 milliwatts of power was going to be better than 300. However, when we did look at the 1,000 milliwatts of power, initially we saw a 21.8% reduction at 1 month. And if we remove those 2 patients that were failed to follow up, we would have seen a 21% reduction in pressure at 1 month. But what we do see is a 30% reduction of pressure at 4 months. So obviously we can see with this question at hand is that 1,000 milliwatts of power seems to be the best treatment choice at this point for MLT.
Dave, just a question for you on this power slide. You've described 3 different power settings. Now, for those of us who have not done a lot of MLT, what tissue response are you expecting? For example, with ALT, we see blanching. SLT, we typically talk about microbubbles. What do you actually see when you're lasering the trabecular meshwork with, and expect to see when you're lasering it with MLT at any of these power settings?
Well, that's a good question. Typically what I see is absolutely nothing. Now that sounds kind of strange because I know with ALT, like you said, you would see that little champagne bubble, or SLT, you may see the little micro bubbles. But with MLT, you actually don't see any effect in the trabecular meshwork. And at first, you're kind of wondering, boy, is this laser doing anything? Am I actually getting a treatment? I know some people will be taught using MLT, and that's for another lecture, but will be taught to use, well, let's set the laser to a certain setting in the continuous wave mode, and then from there we'll adjust it and find out what power setting we should use for the micropulse mode. So they can actually see some uptake, but that's because you're seeing it in the continuous wave mode. For me, I just go ahead and start at 1,000 milliwatts in the micropulse mode. And for me, I feel very comfortable doing that now. I know that I'm not causing any thermal damage to the trabecular meshwork, and also I'm getting the effect I desire. And the other thing too is, as you know, the laser's working because I use it a lot for retina lasers. So I know I'm getting the tissue whitening when I'm doing retina work in the continuous wave mode. So I know my fiber is working, everything's working. And you have to just inherently understand that you're not going to see the same effect as you would with, say, traditional SLT or ALT. Does that answer your question?
Great, thanks, David.
Okay, no problem. I'll go on then. So other questions that we had was, what's the long-term effect? Well, with ALT, we see about an 80% effect at 2 years and a 50% effect at 5 years. With MLT, we're still unknown. We do see a nice effect at 4 months post-treatment, and we do know that the laser is repeatable. Earlier on, I did do a patient who had previous ALT at 25 and 26 millimeters of mercury. I did a 700 milliwatt MLT treatment on them, brought their pressure down. I then hit that patient with 1,000 milliwatts and dropped it even lower. So I know the treatments work, and they also can be repeated. So from that standpoint, I know people are like SLT because SLT is very repeatable. Why traditionally ALT you would treat once and that's about it. You can't really repeat it too much because you're going to end up with PAS and scar tissue within the trabecular meshwork. But with MLT, we know it is repeatable, and that definitely gives us an advantage for treating pressure. So MLT as an option? Well, definitely it's an advantage for the MLT for those patients who lost effect over time. As you saw previously on the slides, we can treat patients who are currently on medication to get a desired effect. We can treat people who have had previous laser therapy, whether it was ALT or MLT, and still get an increased effect. We also know those patients that had a previous laser, whether it was ALT or MLT, you can repeat this laser and use an MLT treatment to try to get the desired effect that you want and hopefully see a lowering of the pressure. So those patients with previous ALT procedures where you couldn't repeat the ALT, this is a great tool to put in your back pocket because it can also help lower the pressure a little bit further for those patients who you want to get them down several more points. So it does benefit the patient, the doctor, because of several reasons. One is it saves money. Patients don't have to pay for their drops. It improves their quality of life. As you know, there's a lot of preservatives in medications. They have a tendency to cause corneal toxicity. If we can try to improve their quality of life by improving their best corrected vision and remove all the toxic effects of these drops, all the better. It also definitely reduces the concern over the level of compliance on these patients. As you know, as a physician, you can tell them what to do, but when they go home at night, do they always remember to use their medications? Are they able to even get their medications in their eye because they may have other problems such as arthritis, or they have difficulty seeing, or being very problematic trying to get that drop into their eye? And half the time when you ask them in their office, did you use your medications, because you see their pressure's up, and they'll say, oh, well, I forgot to take it the night before. And sure enough, you say, yeah, that's why your pressure's up. So you wonder how many different nights before did they forget to take their medication. So compliance has always been an issue for me, and I always want to make sure that these people are being properly treated. And this definitely helps to reduce that concern over level of compliance. And also the other thing is that these lasers have great multiple applications. As a comprehensive ophthalmologist, I can use this laser both for the anterior and posterior segment. When I'm using MicroPulse, though, for the posterior segment, it's a little different than that for the MLTs. What we typically do for this is to find the area of macular edema, and we'll put a test spot in. I usually start off with 100 micron spot size and 100 milliseconds, along with 100 milliwatts of power. I'll then titrate the power by 10 to 50 milliwatts of power until I see a white thermal burn. I'll then switch the console over to the MicroPulse mode. Now, in the MicroPulse mode for retina work, we use a 5% duty cycle. Once again, that's a 5% duty cycle, not 15, but 5% when you're using it for retina work. I'll maintain the spot size, but I'll double the exposure time and also double the power. So here I'll give a couple of case studies using the IQ532 MicroPulse with the green wavelength. First case was a type 2 diabetic who came to the office in December 2nd of 2011. Now, this patient had previous focal laser and grid treatment using continuous wave laser back in February of 2008. They've also had triamcinolone in July of 2008 as well as November of 2008. And finally, they also had a grid therapy along with triamcinolone in February of 2009. And you can see the preoperative OCT, visual acuity of 2050, with marked retinal edema underlying the fovea. So MicroPulse treatment was carried out in December 11th of 2011. Once again, we used that 5% duty cycle. And you can see over a 3-month period, the visual acuity improved from 2050 to 2030 with nice resolution of the central edema after 1 treatment of MicroPulse. Now, once again, this was just MicroPulse therapy. There was no adjunctive steroids or anti-VEGF therapy at this time. Another case was that of a branch retinal vein occlusion of a lady who came in February 22nd, 2012. This patient had no prior treatment. They were complaining that their vision was down for the past 3 to 4 months. Visual acuity is 20/50, and you can see the area of macular edema in the superior temporal range, which is the most common location for branch retinal vein occlusions to occur. The patient underwent MicroPulse treatment on February 22nd, 2012 with a 5% duty cycle, and we can see the visual acuity improved from 20/50 to 20/40, but what we see dramatically is the resolution of the macular edema. Now, if you look real carefully at the date on the slide, you can see that the OCT was carried out on February 22nd, 2012, and the postoperative OCT was only 1 week later. And this kind of really blew my mind the first time I saw this. I said, holy smokes, in 1 week we saw a lot of resolution of the edema. Now, I normally wouldn't bring a patient back and shoot an OCT a week later, but this patient happened to stop by the office and said that her vision was markedly better. She got less morphopsia. She was able to see a lot better. And I thought, well, that was just maybe her mind saying, well, I just had laser and I'm seeing better. So I brought her in the back, put her on the OCT, and sure enough, I saw this result. And this really, really reassured the effects of the MicroPulse treatment and what it can do for some patients. And what we have to think about is that the IQ532 laser, which is the laser I use with MicroPulse technology, has got great versatility. It's a great choice for those with a comprehensive ophthalmology background who want to be able to use this laser for treatment of the anterior as well as the posterior segment. The advantage of this laser is it's also a continuous wave laser, so you can use it for traditional ALTs, for peripheral iridotomies, whether you want to do a focal or grid treatment, PRPs, retinal tears, choroidal neovascularization. And it also gives you the benefit of the MicroPulse for MLTs and grid therapy for diabetic macular edema, branch retinal vein occlusions, many different things that you can use it for retina-wise. And in the future, we don't know. There may be some other applications for this laser that we just don't know we can do yet, and hopefully we'll find out over the next several years to come. Some of the treatment pros I just want to leave with you too is that the MLT with the IQ532 MicroPulse treatment is that you want to use 1,000 milliwatts of power. As you saw in the comparative slide, between 300, 700, and 1,000. I believe that the 1,000 milliwatts, at least in my hands, works the best at controlling pressure without causing any thermal damage and no harm to the trabecular meshwork. By using 1,000 milliwatts, we seem to get the best desired effect that we're looking for. We still use the 300 micron spot size and a 300 millisecond duration with the 15% duty cycle. I typically do not treat with any post-op medications, and I'll follow these patients up at 1 month. However, you might want to see them a little sooner just because of the level of severity of their glaucoma, but you'll feel pretty comfortable that by 1 month that a lot of those patients will have better pressures than before treatment. I do want to just say a special thank you to a couple of residents who assisted me in this presentation, Dr. Warner and Dr. Benjamin. Thank you very much. And I'd like to turn the microphone back to Dr. Ahmed and to move on with the presentations.
Thank you very much, David. That was a fantastic review of the clinical applications of MicroPulse laser for the anterior segment and some nice anecdotes with the posterior segment. One of the things that I want to remind the audience is that we will have time for questions and discussion after Dr. Vold's presentation. But the title of this actually webinar is really talking about, we have many years of SLT data. I've been a long-term SLT user. I find it to be quite safe to use and certainly has been effective. And we pose the question, why do we consider MLT? And I think that's what we want to have in the background of our discussion. And to help us with that, we have Dr. Vold. Steven Vold, of course, I think is well known amongst most circles in ophthalmology. He is the founder and CEO of Vold Vision in Fayetteville, Arkansas. Dr. Vold is a graduate of the University of Minnesota Medical School, did his residency and fellowship in glaucoma at Northwestern, and has really made himself a name both nationally and internationally in glaucoma and intersegment cataract management. He's been involved in numerous trials and particularly interested in new device technologies with glaucoma. And he's going to share with us some of his perspectives on MicroPulse Laser Trabeculoplasty and how this may compare to other technologies and where he sees this going. So it's my pleasure to invite Steven to the webinar. And again, I want to remind all audience members here to hang on after Dr. Vold's presentation for the opportunity to ask questions and further discussion. Thank you.
Thanks, Ike. I'm grateful for the opportunity to talk to you about the MicroPulse Laser Trabeculoplasty. For those who don't know, I've been using this new technology for approximately a year now, and in my practice, I have a tertiary glaucoma practice, so it's a little different than a comprehensive ophthalmologist, but I'm going to show you how I've been using this technology and what I've learned here over the course of the past year. Like to just tell you a little bit of my financial disclosures here. Really, the relevant one here is, of course, my relationship with Iridex as a consultant. As many as you know, we have a number of good initial treatment options. Over the years, we've really oftentimes started with medications. With the cost of medications and a variety of other reasons, laser trabeculoplasty has really become a very common initial treatment. We're going to talk a little bit more why that's the case. Also, there's the advent of microinvasive glaucoma surgery. I think that's also now becoming something that's becoming more and more talked about. That's really not the topic of today, but it's something to keep on your radar screen. And then, of course, for the more advanced cases, filtration surgery really still remains the gold standard of care in glaucoma. Why trabeculoplasty first? Well, I can just tell you right now, medical compliance is really my #1 reason. Patients forget to put their medications, they have side effects, and without question, cost is becoming an increasingly bigger issue in these tough economic times. We also know that it's an efficacious procedure. If you look at the glaucoma laser trial, about 80% of patients have an effect at 1 year. Now, if you go out farther, it's closer to 50% at 5 years, and probably even less than that at 10 years. So this is something that, as we talk about repeatability, it is nice to know that when you have these new, kinder, gentler lasers, that this is something that you can repeat if necessary. And certainly then there's also the quality of life issues, and that's why laser trabeculoplasty is such a good option for so many patients, and also for patients, their out-of-pocket costs are significantly less than just a single medication. When you look at our options, we've had a number of them over the years. When I first learned laser trabeculoplasty, I started with the argon laser. We're going to talk briefly about this. Really, in recent years, selective laser trabeculoplasty has become kind of the mainstay therapy in this arena. And now we have the MicroPulse Laser Trabeculoplasty, and we're going to just kind of highlight some of the differences and why you might consider this for your practice as well. As we look at the options, you can see here the wavelengths are slightly different for each of the technology. One of the things that you're looking at as far as when you look at the mechanism, we have both a mechanical issue as far as the mechanism there, and we really believe that the biologic issues are really a significant part of this procedure, and really maybe the most important part of this procedure. We believe that macrophages will maybe go in and clean up the extracellular matrix area a little bit, increasing outflow through the trabecular meshwork. Clearly, the SLT and MLT appear to be more repeatable than ALT, although some people do use argon laser trabeculoplasty on a second occasion. With the advent of microinvasive glaucoma surgery, I really believe that the ALT very likely will be something that really should be retired in many patients, because if you use this, you're going to scar up the trabecular meshwork and really reduce this other alternative for our patients. So to me, SLT and MLT are significantly better as far as the issue of repeatability and even just keeping other treatment options open. As far as the postoperative inflammation, I'm going to just tell you right now, having used all 3 of these technologies extensively, MLT without question has the least amount of inflammation and really has the least of the complications. And then the question behooves us is, is this procedure as effective as the SLT and ALT? And we're going to talk briefly about that here as we move forward. As you can see, the spot sizes are a little bit different, but with the SLT and MLT, there's no question you get a more thorough treatment of the angle structures. As far as the MLT technique, this is really what I'm doing here. I'm using a 300 micron spot size. Again, it's a slightly smaller spot than the SLT, which may help us access narrow angles a little bit better. I use a 300 millisecond duration. Initially, and I will tell you for almost 6 months or so, I used almost exclusively 700 and 800 milliwatts of power because I just wanted to make sure I didn't overtreat things and end up with all sorts of pressure spikes. I can tell you right now, in recent months, we're really moving towards the 1,000 milliwatt power, and Dr. Gossage has talked a bit about that, and you'll see that by having a little higher power, I think we're going to get a little bit better efficacy long term. It's a 15% duty cycle and 360-degree confluent treatment. Again, I'm doing 360 degrees of treatment on all of my patients. The challenge with this procedure is that you really don't see any visual signs of treatment during or post-operatively with these treatments. Again, what I'm seeing right now is as I've increased my power a little bit, now we're getting really comparable IOP lowering to ALT and SLT, but I'm not seeing the complications that I see with both of those technologies, especially with IOP spikes and post-operative inflammation. Let me just show you here briefly what this procedure looks like under the slit lamp here. And as you can see, it's really a very similar to what you see with a lot of other laser procedures, but it's you're just not going to see the tissue blanching of the trabecular meshwork. This is some of my early data, and I will tell you this is back when I was using 700 milliwatts of data. We've now gone to look back at these patients. Keep in mind, many of mine are tertiary patients, so a lot of these patients are on a lot of different medications. And so I'm really trying to figure out exactly where to find these. And what I'm finding here, even at 700 milliwatts, that I was getting about a 50% response rate. And I now believe that by going up to higher powers, I'm going to get a much higher response rate. And again, what we've shown with the glaucoma laser trial, we really are not going to get 100%. Even in that study, we're getting about 80%. So that's really where I'm kind of targeting things. But even with the lower powers, I was getting 23.2% IOP reduction at over 4+ months of follow-up. We're now starting to get some of these patients out closer to a year. I'll definitely be tracking this very closely. Clearly, I think I'm going to need to use a little higher powers, which we've recently started in recent months. The other thing we're finding is that, especially with the higher powers, we can actually reduce the number of medications by, for me, it's generally a single drop is the way I kind of view this. This is MLT is really the equivalent of a single topical glaucoma medication. As far as some of the observation and treatment pearls that I've found, to me, the beauty of this whole thing is I don't see IOP spikes. Now we've treated over 100 treatments of these with this procedure. I have not seen a single IOP spike. What does this mean for you? It means that there's a safety here that's built in that's really, in my mind, has been unprecedented. I no longer feel like I need to use anti-inflammatory medications, and really, in the past, I've always used aproclonidine or brimonidine perioperatively. I don't use that anymore, and this has been something that it's taken me a little while to get to that. Also, as far as follow-up, generally, I'm having them follow up in a couple weeks instead of the 1 day or 1 week post-ops that I've done in the past. I will tell you, it's very possible we may just say, hey, listen, come back in a month, and let's see what we get for a full effect here of these procedures, which is a significant change for what many of us have been doing with SLT or ALT previously. One of the things, as I've mentioned here multiple times, I do think we're probably going to need to treat these people with at least 1,000 milliwatts of power in the vast majority of patients. I'm going to be watching this with pigmentary glaucoma, pseudoexfoliation. Are these going to need different power treatments? And the answer is I don't know at this time, but this is something we're going to sort out and really hopefully be able to assist doctors with moving forward. As far as some of the similarities between MLT and SLT, it's certainly easy to learn and perform large spot procedures. It's you won't miss the trabecular meshwork here. With ALT, you really had to be much more precise in the placement of these spots. I really do think that this is going to lower pressure as effectively as both ALT and SLT. We were seeing almost no postoperative complications, although with any procedure you certainly can have them. Keep in mind with SLT, you also have the risk of potentially some corneal issues that have been associated potentially with this procedure. We do want to be careful. We don't give corneal abrasions with a gonioscopic lens. Make sure you're using a goniosol type solution to make sure that we don't give these people a keratitis after the procedure. Again, we want to reduce the dependence on topical medication. Without question, I think this can be used early in the glaucoma treatment paradigm. And we believe it's very likely a very similar mechanism of action to SLT as far as the biologic mechanisms. As far as some of the differences, MLT does not produce selective photothermal lysis. MLT, theoretically at least, interacts with the pigmented cells in all trabecular meshwork layers. MLT also potentially can be a little bit more titratable. You have more control. As for instance, you can have the power on and off times adjusted. Certainly the speed of the micropulse repetition you can do. SLT, really, you're just controlling the power of the pulse energy there. MLT does not induce postoperative pressure spikes, and I can tell you from experience that is not the case with SLT. And again, there's just, in my mind, there's no question you very likely get less tissue damage with MLT when compared to SLT. So kind of in summary, which is kind of the big question, was why would you choose MLT over SLT? Here are some of the things that I'm finding, and ultimately you've got to make the decision for yourself. But I think without question it's a very reasonable initial glaucoma treatment option. I will tell you that the MLT, that is with the 532 nanometer wavelength, is significantly better than the 810 nanometer wavelength that I had used previously. I've just found that it's much more effective that way, and just keep that in mind, because I think in the past people have kind of maybe been a little skeptical of MLT. I do think the 532 wavelength is going to show to be advantageous. Clearly it has less tissue damage than SLT or ALT. It reduces the risk of postoperative IOP spikes and the need for postoperative anti-inflammatory medicine. Very likely a very repeatable procedure. Again, I do want to say, before you make any bold claims on these whole things, we really need to publish and really look at our data very carefully. We need more data to collect as well, and I'm hopeful I'll be able to help provide some of that information to folks as well. One of the other things I will tell you about Iridex lasers, they are just some of the best built lasers you can imagine. I've used a good number of these over the years. They're extremely reliable. Reminding to me of almost like in cars. We've had Hondas in our family. These things are just, you start them up and they just don't have problems. The other thing is they're multifunctional, as Dr. Gossage just talked about, and they're very portable. They're easy to use, and they're really elegant lasers. The other things, if you're looking at, it's a cost, which is also a very big deal in these economic times, we know that this is a very cost-effective function. I will tell you, having used the Iridex 532 laser for diabetic macular edema, this is something that clearly has some benefit on the retinal applications, and even for cutting sutures and things like that in the anterior segment. This is another potential option that we have as surgeons. I just want to say thank you so much for the privilege of talking here, and we look forward to answering your questions.
We've got a few minutes now to entertain some questions, and I noticed that a number of you who have logged on have asked some questions, and I want to encourage you to please ask them. If not, then I'm going to be asking Steve and David some pretty tough questions, and I'm sure they want to hear some nicer questions from the audience. So let me start off here, and again, I'm going to take some questions here we have from the audience, and I'm going to first put this one out here to David, who certainly was kind enough to share some of his data. It has to do with where does MLT fit in the treatment paradigm, i.e. first-line therapy. Do you look at it using it in that context more often, or after a medication failure, or do you sort of wait after a certain number of medications have been tried and then look to MLT? And maybe while David's answering, Steven can perhaps give his insight after as well.
This is Steven Vold here, and I'll just take my shot at this here. Can you hear me okay, Ike?
Thanks, Steve. Yep.
Okay, great. Well, here's kind of what I do for me. I will tell you, many patients that struggle with starting with medications don't want to use it. Cost, forgetfulness, just maybe some people just for their reduced quality of life with starting a medicine. Then I feel very comfortable using this as a first-line therapy. I will tell you that in most patients, especially if I'm meeting them for the very first time, they're just a little nervous about having a procedure. And so sometimes I have to admit I will start with a single medication, generally a prostaglandin, and start that approach, and then start with the prostaglandin. If that doesn't do the trick, either after a single medicine or a second medicine, then I will go into laser trabeculoplasty. And I will tell you, for me, for the vast majority of my patients, when we talk about maximal medical therapy, for me, really, it's not more than 3 drops. It may be a combination where it has 2 and a single prostaglandin, but that's about the most I will have folks use. Occasionally, I'll have 4 drops where you have 2 medicines that you're using twice a day. And then I will tell you the other time I'll use it is when people are talking about having surgery and they really are a little hesitant to have incisional surgery. Then I think laser trabeculoplasty in the setting of open angle glaucoma is really helpful. I will tell you one other thing for me, and this is a caveat for people that have pseudoexfoliative glaucoma or exfoliative glaucoma. For me, I'm telling you, laser trabeculoplasty is a fantastic first choice, and in many patients, I will actually recommend that as initial therapy.
Yeah, I agree with Steve wholeheartedly. From our standpoint, I'll sit down and I'll discuss with the patient, their treatment options. Mention that, in the past we used to use medications quite frequently to lower intraocular pressure. Nowadays, we have the ability to use laser to help treat their pressure. A lot of people are starting to now opt, I think, for the laser treatment. I think they understand the fact that they're not having to use medications. They're already on so many different systemic medications, and they prefer not to have to add another medication. They understand that maybe the cost of the medication is pretty high too, and so from a compliance issue, they feel having the laser done, hopefully bring the pressure down, will be fine for them. So from my standpoint, I have a tendency, I think, now to move towards MicroPulse laser trabeculoplasty, just because we know we're not doing any harm. If you look at some of those earlier cadaver slides from Noecker, you didn't see any thermal destruction at all of the trabecular meshwork and on those cadaver slides. So I feel very comfortable going ahead and attempting a MicroPulse laser trabeculoplasty first. And I think the patients appreciate that too, just because they know that they're being treated, they feel comfortable. And the other thing too is, not only the compliance issue, but if we can keep the pressure controlled and keep it consistently controlled, as you know, with medications, you're always going to have pressure that will go up and down throughout the day when the medication starts to wear off. And with the laser trabeculoplasty, I think you get a better, even pressure throughout the time period too. So from my standpoint, I probably opt a little bit more today using laser therapy first versus medications.
Okay, good. A couple more questions here, and they're great. They're flowing through here. So maybe I'll ask both David and Steve because we're getting a lot of questions now, to try to keep these brief here. Now the questions here are about indications. So I'll group a couple questions together here. Can you comment on efficacy of MLT in pseudophakic patients? The first part. And the second part was, what about patients who've had previous filtering surgery, like trabeculectomy or an express filtration device?
Well, I'll take a stab at this here first. Following filtration surgery, and I think this is with any laser trabeculoplasty procedure, I think you're going to have the efficacy is going to be less. You have to be a little bit more careful about pressure spikes, although I have not seen that with MLT. In pseudophakic patients, to be frankly honest with you, if they've just had straight cataract surgery, to me those are very similar to those of just a virgin eye, and so I feel very comfortable doing that. Anytime you've had filtration surgery and have more advanced disease, my experience has been that the results are not always as good.
Okay, we have a question here on a couple users have used the IQ810 to perform MLT. Found that the pressure drop was a little less than what we heard in the presentations here. Any comments on comparing 532 with the current settings versus previous publications or previous experiences with users who've used 810?
Ike, I don't know, David, have you used the 810 for this as well?
Years ago, back in the mid-90s, I had an 810 laser, but I was using it mostly for retina work. And at that time, I didn't have the MicroPulse setting. I think it was on the machine, but it was never turned on. And so my experience with the 810 from MicroPulse is not existent at all.
Well, I did use the 810 for a little bit, and I can tell you right now I had that and an SLT, and at least for me, the SLT was better. I will tell you that my experience with the 532 has been drastically different than with the experience that I had with the 810. So I really think the 532 is a little bit different beast than the 810.
Thank you. Question now is, what is the biggest risk in MLT, and how do you get comfortable with it?
From a risk standpoint, I don't really see any risk for it. The only thing I would not do, though, is I wouldn't really perform on patients with neovascular glaucoma who have peripheral anterior synechiae. Those patients obviously don't perform well with the laser treatment itself. The ease of getting used to it is a matter of just performing a procedure that you'd very similar to doing an SLT or an ALT. The hardest part, I think, of the procedure at first is just not seeing a visible reaction when you're actually applying the treatment. What we do find, though, is that with a little bit the higher power settings, like going to the 1,000 milliwatts of power, even though you're not seeing a visible reaction, the patients do have a tendency sometimes to feel the pulses that are going into their eye. It's not a real bad pain sensation, but they do feel a little bit, and they have a tendency to feel it usually around the 9 and 3 o'clock position. So horizontally, they'll feel the impulse a little bit better or a little bit more. But from the standpoint of ease of use, it's very user-friendly laser. The 300 micron spot size covers the trabecular meshwork very well. And basically just doing confluent laser spots, one right next to each other, doing it for 360 degrees. I use a rich 4-mirror lens, so typically I'll do about, say, 25 pulses for each quarter within the 4 mirrors, and you end up getting about 100 pulses, anywhere between 95 to 110, with one full treatment.
A number of questions from some of the audience members about SLT and relationship to what the role of MLT is. So we've had some users who have had experience with SLT, and what would they expect moving over to MLT, and then some users here I see who are looking at comparing and looking at whether to go, and look at the SLT route in terms of preferred for their practice or an MLT. So maybe comments on maybe we can I'll ask Steven and David about, number one, the clinician who's been using SLT. Many of us have used SLT for many years, and are now looking at MLT, and then for those that have not really had a device in their practice but looking at getting a device. So maybe we can start with the first group. On those users, SLT users currently.
Well, I'll just say for those who have an SLT, one of the things that I found, at least in the past, is that the SLT was a little bit of a sensitive laser, and so we would at times have that thing break down from time to time. It's also a little bit more limited in its functionality. And so for people that have SLT and it's working well, I'm not sure you have to reinvent the wheel, but if you're purchasing another laser and you want one that has multiple functions, the Iridex laser, the 532, is hard to beat because, as David illustrated so nicely in his talk, is it has so many different functions. It can be used for a wide variety of both anterior segment and posterior retinal functions, and to me that works really well. The other thing is it's very economical, it's very portable, and the other thing, as I mentioned in my talk, was this thing is an extremely reliable laser. And for me, when I had an opportunity, I also was a startup practice here just 2 years ago, when I was looking at different options, certainly SLT was one that I considered. But for me, this MLT has been just a fantastic laser because of its multifunctionality.
Yeah, I agree. If you're going to go out and if you already have an SLT laser, you're not going to go out and buy this laser to replace your SLT laser. However, if you're leasing an SLT laser or just using it periodically from another partner or the hospital, and you're looking for something that you can have in your office, or if you have multiple offices and you want something that you can bring from office to office, this is a great laser. I mean, it gives you multiple platforms for treating the anterior and posterior segment. If you have a multi-specialty practice, someone who does glaucoma, someone who does comprehensive ophthalmology, this laser really, really will cover everything for you. And I hate to say it, it's a lot less expensive, too, than the SLT laser, too. So from my standpoint, it worked out great for me because being a comprehensive ophthalmologist, I was able to get a laser that I can use not only to treat glaucoma, but really to treat the retina issues too.
So I'm coming at this, as a fairly new user. I mean, I've had, many years of SLT, did a lot of early SLT work. I think SLT certainly has shown success, of course, and I certainly wouldn't be one to be negative on it. I think all of us have realized that. And my observations are, as you mentioned, I mean, I'm very impressed with the with the quality and with the performance. And what most took me was, and David mentioned, I asked David this question online, was just the tissue response. I mean, when we're doing this, I'm kind of wondering, am I actually having an effect here? The eye is unbelievably quiet. That was probably the first thing I remarked, and I honestly had questions, and I still will have a critical eye on this as far as am I going to get a response? I don't see much going on in the eye. When we're doing SLT or certainly with ALT, we're seeing blanching or we're seeing micro champagne bubbles, and we're seeing some cells in the AC, and quietness really took me to this one. So I'm looking forward to our results. There were some questions here on published studies, and I think these are going on. We're looking forward to starting our prospective study and comparative study, comparing the MLT versus other platforms. So I think this is new and emerging technology here, and I think it's great to hear from two speakers who've had some experience around it. There was a question here simple question here was this regards to billing. This must be from a U.S. physician. How do you bill for MLT, and what's the CPT code?
Well, the CPT code is a 65855, and that's for laser trabeculoplasty. And in the CPT code book, it really doesn't define whether it's ALT, SLT, or MLT. So currently, right now, we're using the 65855.
And keep in mind, it used to be a 90-day. It's now just a 10-day global period.
Okay, and a couple questions here with regards to David had some comments about your retina applications. I wonder if you can give further information or further treatment about further details about your parameters for retinal laser.
Sure. When I'm treating the retina, the nice thing about this is it's completely different than what you're used to with continuous wave laser. You have to remember that this laser in the micropulse setting is really what we call foveal friendly. It's a great laser to be able to treat because you can come right over the fovea without the risk that you would get with, say, a continuous wave laser. Typically, what you have to remember, though, is that when we're doing retinal work in the micropulse setting, we're using a 5% duty cycle. And I want to repeat that. It's a 5% duty cycle, not 15% that you would use for doing trabeculoplasty, but a 5% duty cycle. And what I typically will do is put it in the continuous wave mode first. I'll start off with 100 micron spot size. And then what I'll do is start off with 100 milliwatts of power. I'll then titrate that up by 10 to 50 milliwatts of power until I see a little retinal whitening. Once I see the retinal whitening, I'll switch it over to the micropulse mode. I'll put in the 5% duty cycle. I'll leave it at 100 microns, and then I'll double the power setting for where I left off and double the duration. So if it's 100 millisecond duration, it goes up to 200. If it's 100 milliwatts of power, I'll double that to 200, and then I'll go ahead and treat. And what I do is I really use a high-density treatment over the area of the retinal edema. And so what you're doing is you're putting in almost like a PRP right over the area of edema, whether it's over the foveal avascular zone, whether it's directly on the fovea. You can go ahead and treat it and feel comfortable that you're not going to cause any thermal damage. Afterwards, if you were to shoot a fluorescein on them or do autofluorescence on them, you're not going to see any change in the retina at all afterwards with these settings. Now, the other thing I have been doing a little bit lately is actually increasing the power just a little bit more. So I may even go up to 400 to 500 milliwatts of power. I still feel very comfortable as I shoot a fluorescein afterwards. You're not really seeing any changes in the retinal architecture at all at that point. But to remember that you have to use that 5% duty cycle. And like I said, it is very foveal friendly. You feel very comfortable when you're treating these patients who are bad diabetics who have a lot of macular edema. And that macular edema that's underlying the fovea is always the hardest to get rid of, and this laser works great for it.
There's a question here about the energy settings and for MLT in terms of any experience using higher levels, 1500 2,000 milliwatts, playing around with the duty cycle. Anyone have any experience on that or thoughts on that?
I do not yet. I have not tried over 1,000 milliwatts. I'm not sure yet, but I do know, at least with the cadaver studies, that 1,000 milliwatts at that time did not show any thermal damage to the trabecular meshwork. I am unsure yet at this point of using higher settings.
Yeah, I'm in the same situation with David. Honestly, I think I probably undertreated a bit over the first year significantly, and over the last 3 to 6 months, I've really increased the power settings, and I think I've really benefited as far as the amount of efficacy. Now, I'm not sure I'm going to need to go up to 1,500 milliwatts to get an adequate treatment here. I've really been pretty pleased, honestly, with 1,000. And to be frankly honest with you, as David said, when you get up at 1,000, they can start to feel this a little bit. So there's something going on. I think I'd have some very unhappy patients if I started using 1,500 milliwatts of power. What do you think, David?
I agree. I mean, 1,000 milliwatts, like I said, they do feel a little bit. It seems like they feel it more in the horizontal meridian around 3 and 9 o'clock. But, I'd like to see really an E&M microscope of the trabecular meshwork with a little bit higher setting just to see what type of thermal uptake you get.
We've got a couple of minutes left, guys. One question here on retreatment. How often have you needed to retreat? Any retreatment results yet?
What I found is actually patients who have had MicroPulse treatment at the lower settings, when I was doing 300 milliwatts and 700 milliwatts of power, the interesting thing is that they responded very well to the higher power settings. So in those patients who you treated, they had a good response for 3, 4, 6 months, and then their pressure started to go up again. By that time, I was already now using 1,000 milliwatts. So those patients I converted over to 1,000 milliwatt setting and would retreat, and they still had a nice response with 1,000 milliwatts. I did have one patient, actually, I think they just came in yesterday, who's been out probably 6 or 8 months with 1,000 milliwatts of power, and the pressure did rise back up, not quite as high as it was before the initial treatment, but it did rise, and we retreated. So I'm not sure yet how they responded. I'll know more in the next couple of weeks or so, but retreatment-wise, I at least found with the 1,000 milliwatts power, it's much, much less than it would have been with 300 or 700.
Well, thanks, guys. It's about a minute left, so I'll just wrap it up here. And I want to thank both David and Steve for excellent insights into MLT. Like I said at the beginning, glaucoma is a disease that I think we're continuing to learn more from, and we're continuing to look at further intervention. I think drops have had their day. I think that using other intervention like laser and microinvasive glaucoma surgery and other options, I think, are on the horizon or are here. And it's just great to have another option for laser trabeculoplasty. We've seen, let's go from ALT to SLT, and now we're looking at MLT. So I think it's encouraging and exciting. I want to thank you both for participating here. I want to thank the audience members for listening up and their questions. And thanks, Iridex, for helping us put on this webinar. Thank you very much. Have a good night.
Well, thank you for your presentations. We would like to remind the audience that you are able to schedule a demo by visiting www.iridex.com/IQ532demo. This concludes tonight's webinar.